We are going to break away from Dr. Ino's case, and we'll have a talk by Dr. Shah. Dr. Shah is from the University of Colorado at Denver. He's an associate professor, and we'll be talking on, what's the topic, Raj?
ERCP update.
On a ERCP update.
So thank you again. Thanks, Atul and Stavros and the course directors. I know how much work it takes to put together a live course, and we've been running our endoscopy course in Colorado for 10 years now, and it's really just a fantastic course this morning. A lot of great cases and techniques that are shown, some of which you'll apply, not necessarily into your respective practice. I don't think you're going to start doing ESD tomorrow or Monday, but I think some of the techniques that are applied with controlling of hemostasis, performing hemostasis, clip placement, those kind of things are very valuable to see how they're done by experts. So I'm going to be changing gears a bit to talk about ERCP, and Stavros had asked me to talk about kind of three highlights of 2013 or coming up in 2013, maybe last year as well for ERCP. So I thought, as most ERCPists would consider, strictures and stones are sort of the basis for what we do with ERCP. There's also this thing called sequestration, and I think we're hearing Congress use the term, and I don't know if I'm going to be using the term correctly, but I'm not sure they are either. So we'll see how that applies to ERCP. Some disclosures are listed on this slide. And sometimes we'll see this scenario, and you probably hear this from patients. The brushings, biopsies, they don't show you have cancer, but it is still possible that you have cancer. And that's a very common discussion that I have with patients, because we come across this. We think it's malignancy. The biopsies don't necessarily suggest malignancy. And we're left with this dilemma of what do we do with the patients, and what kind of interval do we decide that we should survey them to look for cancer. And from the patient's perspective, we sometimes forget that they do a biopsy, and they would intuitively, you would think, well, if I do a biopsy, then I should get an answer. Yes, there's cancer. No, there's not cancer. So many times we're kind of reassuring them, and also cautiously reassuring them if sampling is negative, because our index of suspicion is high, and that's where some of these more advanced techniques come into play. And the reason it's important to confirm malignancy rather than shifting them off to surgery right away in the setting of pancreatic and biliary malignancy is that it can expand and really expedite treatment options. And as you know, with pancreatic and biliary cancer, there's a low rate of resectability. And maybe in the future, this will become a metric for quality, is what's the time to diagnosis patient presents with biliary stricture or symptoms that suggest that, and what's that time to get to an answer. And that's really all the patient cares about. They don't want they want to have as few procedures as possible. They want an answer, and then they want to know what's happening and then move forward. And that's their perspective. We have to think along those lines. And a lot of this minimally invasive endoscopic treatments you're seeing today are just that, trying to get to the end point of resection and removal or treatment in the case of palliation. One of the challenges with sampling, though, is that there's low rates of sensitivity in detecting malignancy. And I'm going to focus primarily on cholangiocarcinoma. And if you look at biopsies and brush cytology, their yield can be anywhere from 30 to 80%. And I think in most practices, when you informally survey both in referral centers and in community centers, the rates of sensitivity are under 50% for brush and biopsy. And biopsy actually is not used that commonly in the community, more so used in the referral centers when it comes to biliary sampling. FISH is something that many of you may already be incorporating in your practices. It's fluorescently labeled DNA probes that are actually looking for chromosomal abnormalities. And there's actually 4 to 5 different abnormalities that are looked for, and polysomy is really what you're interested in. Sometimes the pathology. How many of you use fish in your practices? None of you. Okay. Well then, should I move on? No. Well, and I thought maybe you guys were utilizing it, but I think that the polysomy, you'll hear about trisomy, nullisomy, a variety of different differences with fish, but polysomy is really what you're looking for, and it can be predictive potentially for the development of malignancy. And these probes that are colored probes, there's a 5-3-2 rule, so you need at least 5 epithelial cells, 3 different chromosomal abnormalities that have at least 2 light-ups per abnormality. That's polysomy. The problem with it is that an isolated polysomy may not necessarily predict malignancy. And in this series from the Mayo Clinic, which is really where the evaluation initially was reported, one of their pathologists put it together. But they looked at follow-up of specifically PSC patients with primary sclerosing cholangitis, and had about 100 patients with polysomy. But those that did not have confirmatory testing, only about 18% that went on to have subsequent FISH testing and non-polysomy had actually cholangiocarcinoma. So an isolated FISH polysomy doesn't necessarily mean you're done. So I wonder about the utility of it in some cases where there's an indeterminate diagnosis of a biliary stricture. So there's some evolving techniques and technologies, including imaging, such as cholangioscopy, confocal microscopy. We looked at it with the stomach and the esophagus this morning by Dr. Gress. And then some palliation, EOS-guided biliary drainage, an excellent case that Stavros had shown, and some other techniques to palliate. I think the purposes of these palliations are really to reduce the frequency at which we do intervention. And I think that's the focus of my talk today. So this is an example, a patient who actually had 5 prior ERCPs at an outside institution, and actually had not only 5, but 3 previous cholangioscopies, spyglass cholangioscopies. And you see this filling defect in the common hepatic duct. Stricture, could that be a post-chole stricture? Could it be malignancy? And this is actually normal intrahepatics. And this is actually the spy-bite forceps that's being advanced. But this clear demarcation between normal mucosa in the intrahepatics, and then you see this kind of circumferential, abnormal, infiltrative appearing stricture with some ulceration, erythema. More so than the abnormality, I think, is the stark contrast with normal intraductal intrahepatic ducts, and that in and of itself is worrisome for malignancy. And directed biopsies can be performed. And in this case, directed biopsies had shown high-grade dysplasia, and the patient's being evaluated currently for resection because it looks like a type 2 cholangiocarcinoma. Sorry, bismuth type 2, where you just have extension into the right and left main hepatic duct, and it looks resectable. These are some examples, some cholangioscopy images of cholangiocarcinoma. Intraductal masses are here, infiltrative stricture, fairly concentric, but there is some ulceration and infiltration to the stricture. Most of the nodular cholangiocarcinoma that's reported in the literature is usually from the Far East and their experience. I think here in the U.S. and Western population, we see fewer of these intraductal masses, see more of these sclerotic, fibrotic types of cholangiocarcinomas, which tend to be a little more challenging to diagnose. And the largest trial of using SPY cholangioscopy, 15 centers, my former colleague Young Chen spearheaded that series. And they looked at the SPY impression and the sensitivity in detecting malignancy. 95 patients had complete follow-up. You see 78% sensitivity, specificity 82%. The negative predictive value is 77%. So you might think, well, that's getting close to what brush cytology is, so why do SPY? Well, this is a very select group of patients who the majority of them already had some degree of non-diagnostic sampling. So you're looking at a pretty select group of patients that are actually already hard to define. But in this series, though, you're still looking at suboptimal ability to detect or exclude malignancy. So there's some limitations of cholangioscopy. And primarily, we end up doing cholangioscopy after stents have been placed across a malignant appearing stricture. So sometimes stents may alter the interpretation, or if you have to dilate the stricture in order to get the cholangioscope across as a 10 French scope, and sometimes just the dilation can alter your interpretation of the imaging. So it brings me to confocal microscopy, and this is being utilized in indeterminate biliary strictures at select centers. It's a 3 French laser fiber, so it can pass through an ERCP catheter or a cholangioscope. The advantage to this is that you probably don't need to dilate a stricture prior to interrogation. It's limited, though, in that you can't do tissue sampling. You still need to do tissue sampling, but it may help and target the location of where you do your stricture sampling. So the field of view is noted here. The imaging depth is 40 to 70 micrometers below the tissue surface. And the Miami criteria have been established to help in trying to distinguish between what's healthy, normal bile duct and what's abnormal. And so I know that sounds kind of simplistic, but that's kind of where we are right now with confocal microscopy in the bile duct, where it's a standard definition probe. It's not a high definition probe. What we're seeing with healthy bile duct is a normal reticular pattern, some light background. You'll see some fluorescein uptake in the vessels that are less than 20 micrometers. And that's felt to be healthy. Now, what is in stark contrast to that of healthy is abnormal. So you still see some dark clumps, thick dark bands, epithelial structures, and thick white bands. Thick white bands are greater than 20 micrometers, which is a reference point on the machine itself. Usually we look to see if there is at least 2 criteria to say this is malignant or not. In one of the first series published in GIE, we had looked at 89 valuable patients, and the sensitivity was quite robust compared to index pathology. Specificity, you'll note, is lower. It's an imaging modality. It's going to overshoot some of the detection for malignancy. But I think the negative predictive value and sensitivity of this technology thus far in preliminary multi-center series is what's encouraging. If you're able to tell a patient that with a high degree of certainty that they have benign disease, that can be reassuring for both you and the patient. And that can't be underestimated or undervalued. I'll give you, this is a good case. Well, you make the judgment if it's good or not, but this is a patient who presented with abdominal pain, weight loss, and abnormal LFTs, and you see this somewhat eccentric stricture in the distal bile duct. You can see it again here. They do endoscopic ultrasound, which we usually will approach indeterminate strictures with the EUS as well, and we don't see a clear mass in the head. In fact, you see some stricturing here in the bile duct. You follow the pancreatic duct to the head and don't see a clear mass. So you're thinking, okay, well, this is, I don't see a mass, but it should be benign. So 2 months later, she underwent a cholangioscopy, and you see some irregular margins to the stricture. There's an ulceration, asymmetry, slight infiltration. It makes you worried a little bit about malignancy. So we perform confocal microscopy, and what you'll see here, if I can pause it right around there, and if I trace it back a little bit, and actually with the system now, you can't actually pause and go forward and backward, and you'll see what's been described just recently published, the Paris classification, where you see some thickened reticular pattern, which may be or likely to be inflammatory changes, and not just benign, healthy changes, but inflammatory. But nothing that looks dysplastic or malignant. And in fact, with multiple stenting, 5 months later, this is how the stricture looked. And actually now at about 11 months, she's doing well clinically, still having pain, but not having continued weight loss and no signs of malignancy. A PSC patient, which is another place where we utilize this, you see some diffuse stricturing. And you see diffuse stricturings, and do you guys see PSC patients in your practice? Primary sclerosing cholangitis? All these dominant strictures are the left main, right main duct, and sometimes we're not sure exactly where to sample. In this particular case, and this has actually been published now our first 20 patients using Confocal with PSC in DDS. And this patient in the left main hepatic duct actually had some dark clumps, some epithelial structures. The brush cytology was read as atypical. The patient subsequently went on to liver transplant, and there was actually areas of high-grade dysplasia within the areas that correspond to what we were seeing by confocal, but not necessarily detecting by cytohistology prior to the transplant. Just an example, I think, of how the pathology can correlate with what we're seeing with confocal. And so a multi-center series is being presented at DDW this May, in which we looked at 46 video clips using confocal specifically in PSC patients, which tend to be a challenging case, or challenging patients because they have a high rate of development of cholangiocarcinoma. There's multiple targets to sample. So you're trying to figure out which areas to sample. This can sometimes be useful, still under investigation. But you can see that the sensitivity, specificity was actually lower than compared to tissue sampling. We had a high proportion of patients that had malignancy, and there's a pretty select group of patients. But when you combine confocal and tissue sampling, you see very robust sensitivity, negative predictive value. So again, in a case where you have PSC and multiple strictures, if you can reassure patients that, okay, maybe we don't have to do a surveillance interval imaging study in 2 or 3 months. We can follow LFTs and perhaps not do rigorous sampling every few months. And that's where I think the technology is going. It's not quite there yet, but I'm hopeful that it will allow us to reduce the frequency of interval of surveillance sampling in patients who don't need it, and then increase it in those patients who do need it. So there's some therapeutic interventions I wanted to touch on as well. And radiofrequency ablation for cholangiocarcinoma, I think, is one of the interesting novel techniques now. It's a probe that actually I have a picture of it here. 2 electrodes that provide a coagulative necrosis over about 2.5 centimeters, approximately 2.5 centimeters. And this is over the wire. So there's a little hole here. You can put an 035 wire up into the bile duct and actually do RFA just like you would in the esophagus for Barrett's, anywhere from 90 seconds to 2 minutes, either above the bifurcation or below. And there have been a couple of series, actually this one series in GIE that was published from David Westaby's group and Nagy Habib, who the catheter is designed by him. 22 patients, 16 pancreatic, 6 cholangio. The mean stricture length about 4 centimeters, did about 2 applications at this joules. And they looked, short-term data, 90-day patency of metal stents, so they would put metal stents in immediately after the RFA. 76%. It's a little hard to know what the long-term, this is more of a proof of concept and safety data phase 1 study. There's some complications, including cholecystitis, which these are patients that had some degree of malignancy involving the cystic duct origin. And at DDW this year, Michelle Cahala, and I'm one of the co-authors on this in this series of 36 patients, mean stricture length. And we looked at the pre-RFA, post-RFA mean stricture diameter, showing some numerical increase in diameter immediately. And we'll have to see in the presentation how many of the 36 actually had that data. Morbidity was kind of modest. The idea of this is really that these are unresectable patients, and you're going to try and reduce the number of ERCPs that are being done to maintain patency. This is an example, and I'll make this a little briefer. 79-year-old with Caucasian male that has had symptoms of malignancy, basically, and obstructive jaundice. These are some of the labs. INR, though, is quite high, 3.4. Bilirubin was 25. Most of that was direct. So it seems less likely to be cirrhosis or maybe underlying cirrhosis and a superseding malignancy given that coagulopathy. So I'm going to take you through the CT scan, and you can see that there's dilated intrahepatics here and the dilated main duct, but you also see the pancreatic duct here. It's dilated. And I'm going to trace that through, and you can see in the pancreatic head there's a cystic lesion there. And endoscopically, You probably recognize this as a fish mouth or fish eye. I've actually seen both terms used. This is actually mucin extruding from both the bile duct as well as the pancreatic duct. Makes you wonder, the PD looks bigger, so maybe it's a pancreatic primary, but you don't really, can't tell that from the endoscopic image. But the reason that I saw the patient is because he was persistently jaundiced. He had a couple of plastic stents placed in the community, persistent jaundice. So we thought, well, it makes sense to put a covered metal stent in. So this is actually mucin in the duct. And this is actually a SPY cholangioscopy view. I should say that part of the reason we did this is because we didn't have a tissue diagnosis. There's suggestion of mucin, but not a tissue diagnosis of either malignancy or dysplasia. So you can see these villous fronds within the duct. Still, you're going to ask, how is this changing management? So we're doing directed sampling. So we do directed sampling, get a diagnosis of mucinous cystic neoplasm. Well, you kind of knew that from an EUS that was done previously. Put the covered metal stent in, but part of that SPY was done to try to mark the areas on the upper and lower margins of the bile duct before RFA. So the covered SEMS that I had put in, it actually migrated. And jaundice persisted, so what do we do next? So this is actually the SPY catheter at the upper margin of where I saw villous lesion on the bile duct side. And then this is the lower margin, again, marking it with cholangioscopy guidance, the villous lesion, both proximal and distal. It's not a stricture that we're dealing with, but more a villous mass. So applied RFA at one occasion, multiple stents. This is actually the catheter that you can see the radiopaque marks that mark the upper and lower margin of the treatment zone. And I applied it, I overlapped it. Usually we do 10 watts for about 90 seconds. And in the upper margin and then overlap the lower margin. On follow-up, maybe I can convince you there's less mucin, but I will tell you that the patient had resolution of his jaundice after 2 sessions of RFA, became surgically more fit, his nutrition improved. 2 months after our index, actually 3 months after our index treatment, he went on to resection. He had some local invasion of the portal vein. They did some grafting, but he's doing well. He was in the hospital 6 days post-Whipple, doing well. But at the time when the surgeon first saw him with a Bili of 22 and poor nutrition, he actually was not surgically fit. So I think it helped change management in improving the patient's jaundice to allow him to proceed to resection. The other area, and I think the last area, which I have about maybe 5 minutes, you think, Atul? 5 minutes or more?
Okay. Go ahead.
This is an example. So you think, okay, this lady's got a gallbladder stone. They just need a cholecystectomy. But if you look real close, there's surgical clips there already. So I don't know if you've encountered this, but occasionally when patients come in with acute cholecystitis or significant inflammation in the gallbladder fossa, they're doing these laparoscopically, obviously. But in some cases, you can have an incomplete cholecystectomy. And that's exactly what was noted here. Many times you say you would ignore the stone, but this patient was having symptoms just like there were symptoms when she had her gallbladder intact. So it made sense to me to pursue treatment of this stone stuck here above the cystic duct. The other tricky part of this is that she has an aberrant takeoff of the right posterior intrahepatic duct. That aberrant takeoff is coming off the neck of the gallbladder. Very unusual anatomy. Now sometimes you'll see the right posterior intrahepatic come off of the cystic duct, but to actually come off the neck of the gallbladder, you're kind of limited. You can't do a completion cholecystectomy in this patient either. At least I don't think so. I don't know if there are any surgeons in the audience that tell me otherwise, but so this is an example using cholangioscopy, and we actually had a little trouble getting into the cystic duct selectively. So this is actually the wire going into the cystic duct, and then that was the lumen to the main portion of the bile duct. So we used the cholangioscopy guidance to actually just help us steer our wire in the right direction. And then you'll see some filling. I'm sorry if it's a little dark for you, but that's actually the area where the stone is. Now that cystic duct and the valves of Heister, they're pretty resistant to passing devices through there, and there's a stricture there too. So we initially attempted cholangioscopy, we were unable to do it, so we had to dilate. Now, We don't normally like to dilate the cystic duct, but we dilated it with a 6 millimeter balloon. And then this is actually a view of the right posterior intrahepatic, just to convince you that it's really in the neck of the gallbladder. And so the wire is here, which is in the remnant gallbladder, and you see a stone right where we would expect it to be based on the cholangiogram. And then subsequently, intraductal lithotripsy is performed with EHL, electrohydraulic lithotripsy. And if you're not familiar with the technologies, there's two electrodes that energy is transmitted to the electrodes. It creates a spark gap between the two electrodes, and that, through an aqueous medium, will actually transmit shock waves to allow breakage of stones. And in this case, actually, this was the first session of intraductal lithotripsy. She actually went on to a second session, and then just this past Monday, I did her last ERCP, and you can see a difference in the missing stone here. Now, I have to admit, I actually ended up putting a stent back in because I wasn't sure if there might be something hiding right up there, so I'm actually going to bring her back for one more cholangioscopy, which the patient was pretty disappointed with, just to be sure that there's no other stone fragments there. So these are some of the series of cholangioscopy. This was actually our group in 2007. You see rates of clearance that range from 80 to 90%, 80 to almost 100%. Part of that difference in clearance is related to the percentage of intrahepatic stones. We are not as good in clearing intrahepatic stones compared to extrahepatic duct stones, which the intrahepatic ones tend to be more challenging. Now, whether laser lithotripsy, I don't know if any of you use laser lithotripsy in your practices with cholangioscopy. So I'm just going to go through. There's some interesting data. Sandeep Patel from UT San Antonio did some bench testing using laser, putting it up against the porcine bile duct, and really seeing significant differences in time to perforation. So he tries not to go beyond 8 to 10 watts of power when you're using laser. And part of that's even is well demonstrated in this abstract, which unfortunately has not been published yet in a peer review. But needless to say, it adds some significant information for us to what our safety margin may be in using laser in the bile duct. And I'll show you a quick video. Now, we're going to be doing a SPY case, I think, during the next couple hours here. But that was a stone stuck. A stone stuck between the cystic duct and the main duct. And the reason I wanted to show you this is because this is actually during one of our live courses. And, you know, sometimes with SPY, you have a lot of devices here, a lot of handles. You got your endoscope and then the SPY scope. We use a syringe that's on the working channel. We use a Y adapter on the working channel, put a syringe on the end so that you can irrigate and then aspirate. You know, there's no suction on the SPY catheter, so we use that syringe on the end to actually irrigate and aspirate. You get a clearer view, that cycle of irrigation and aspiration. And then this is the holmium laser that has a green target light. The light itself is actually not the laser, it's more of the target light. And you want to be, depending on the firmness of the stone, you kind of want to paint the stone. If you get kind of stuck in a stone, you can kind of tunnel it. That may be good, may be bad. You can sometimes tunnel, break up a hard stone, and then switch to EHL to finish the job. So I'll cut through there and talk the last couple of minutes on pancreatoscopy using intraductal lithotripsy for pancreatic duct stones. And our data on this is in about 50 patients published this year, actually in press, in pancreas. There's some technical failures that are related to downstream strictures of pancreatic duct stones. Most of the literature will, when they talk about calcific pancreatic stones, will utilize SWAL, extracorporeal shockwave lithotripsy. One of the reasons we utilize pancreatoscopy and intraductal lithotripsy as a primary setting is because SWAL generally does not obviate the need for ERCP. So from a patient's perspective, in our experience, patients are alcohol-related, tobacco-related, sometimes genetic. The genetic ones tend to have less stricturing disease, but by and large, the more patients we see have downstream strictures. If they have downstream strictures, they're going to need stricture dilation and stenting. And so at that same time, we can do intraductal lithotripsy. So to me, it just makes a lot of sense. We were working on doing a randomized controlled trial with the 5 centers of using S-wall pancreatoscopy, but it's been a little hard to put that together. But that's been my bias, is using intraductal lithotripsy. We get pretty good clearance rates and pain improvement at intermediate term follow-up. This is an example, actually, a young kid with hereditary pancreatitis. You see some stones here in the PD, dilated PD. And this is the stone. I'm not going to show you the video. Needless to say, we broke up the stone during the same session. And on follow-up pancreatogram, the next session, so that's index session with intraductal lithotripsy, follow-up, you can see a remarkable decrease in the diameter of the duct and then clearance of the stone burden in the head. Really, this is not an endpoint for this young patient. He's got hereditary pancreatitis, familial, high risk of pancreatic cancer. He'll go on to total pancreatectomy and islet cell transplant, but he was only 10 or 11 years old. They want to wait some time before they do that. So in that case, it worked out really well. And a multi-center group, myself and Michelle Kahela and Sandeep Patel, Isaac Ryman, we put together last EDW, 28 cases. This, you see complete clearance in a majority of patients, complete or partial clearance, and with clinical improvement. But that's sort of preliminary data without long-term follow-up. So lastly is reducing post-ERCP pancreatitis. And I unfortunately did not have enough time to talk about all these areas, but I think I think it's still wire-guided versus push and inject techniques for cannulation. I think the data is all over the place. I think you go with what you're most comfortable with, and we can't definitely say that wire-guided cannulation is the way to go to reduce risk of pancreatitis, because we see it in that setting as well. Mm-hmm. Small caliber pancreatic stents if they're high-risk patients, and that I think has been probably embedded, and there's nothing new about that except for potential complications of stenting. This is probably the biggest thing, rectal indomethacin. Are you guys utilizing this in your units, rectal indocin? So there's plenty of data, meta-analyses in GIE last fall, and in the randomized trial you're aware of from the New England Journal, a few sites, looking at a clear reduction in post-ERCP pancreatitis. So we actually have indocin in our, it's not in our Pyxis, but in our ICU Pyxis, which is just a couple doors down. When we know from the beginning of the case we're going to need it, they'll get 2 50 milligram suppositories. It's cheap. Nurses don't necessarily care to give it, and sometimes they ask us to do it just to equal out the burden. But intraprocedurally, when you know you're going to do it or need it, you can go ahead and give it. In the studies, primarily they're done immediately post-procedure, but you can give the suppository while the patient's semi-prone. And we've been probably using it regularly now for the last 6 to 7 months or so. And we'll see if it's really making a difference. But there's plenty of literature, I think, to suggest it.
So, Raj, excuse us. Can we just break into your lecture and come back to it? Because sure. Dr. Ino has something he wants to show us. He's finishing up the rectal ESD. So let's switch to Dr. Ino's room. We'll come back to your lecture and finish it. Sorry about that. I know you're almost ready to finish.
Right upstairs.
All right, Dr. Ino, we're with you.
Can we have a specimen?
Dr. Ino, you're on the air.
Thank you very much.
You can open it up.
If possible.
Yeah. Oh, you want to see it? Yeah. Maybe I have to push that. Oh, it's flipped.
Okay.
No, it's
Okay.
supposed to be upside down.
So can you hear me?
Yes, we can hear you.
Hello. Hello.
Hi, Dr. Ino. We can hear you.
Yes, sir. This is nothing special, but the tumor has been removed in an unblocked fashion. So because we encountered some large vessels, so we coagulated it. And then looks like well done, not a medium layer. Hello. But anyway, so can you hear me?
We can hear you well.
Okay. So like this. So nothing special. But we finished tumor resection. So finally, we resect the retroflex view from the rectum. So we resect the tumor like this. So retroflex view. Yes. In a retroflex view, we resect the tumor. So most of the submucosal dissection done from the rectal side, anal side, and then finally proximal side and retroflex view. And then this is a resected specimen, so unblocked fashion. So like this.
Very nice.
Okay, thank you very much.
Okay.
Yes. We thank you too.
All right.
Thank you.
It seems like a lot of work for something you probably could have snared off with a good fluid cushion, but that's
Yeah.
okay.
All right, we'll come back to your talk, Raj.
Oh, so, rectal endoscopy we're talking about, and just consider utilizing it. I think whether we utilize it in all native papilla cases or not might be a bit of debate, but it's inexpensive, easy to administer, so something to consider. So I just wanted to conclude by saying that, there's some advanced imaging techniques. What's the ERCP sequestration then? It's really all these technologies, I think, is designed to try to reduce the frequency in which we're doing ERCP, because I think it's a matter of a short period of time that we're going to be getting less reimbursement for these procedures, and what are the new technologies that are worth investing into to try to reduce the frequency still remains to be seen. But so I think earlier cholangioscopy, directed sampling, can improve the detection of malignancy in patients with indeterminate strictures. Confocal imaging may be helpful as well. And then palliative therapies such as RFA. And then stone disease, if you have a difficult biliary stone and you can't get the stone out, and you think the next time you're going to do the same kind of techniques that you did the first time, and you're not going to take it up a notch, with a different type of basket or cholangioscopy, EHL, and you think you're going to just let the stent soften up the stone, think twice. I think it's better that the patient go either to your senior partner or to another center, such as this one, where they can have the equipment to take care of the stone the next time. So I tell patients there's a 90% chance that we'll clear your stone with a follow-up, meaning after referral, 90% chance that they'll have their stone cleared that day. Most of them are pretty happy with it. Some want to hear 100%, but that's the reality. So anyway, thank you for your attention.